Hello everyone, I am Dr. Omkar Sangita Diliprao Sonone from team FMGE, and today I am back with a very important and high yield topic from the exam point of view, and that is multiple myeloma. I hope all of you are quite aware that multiple questions from the same topic have come earlier in the examination. The recent pattern of examination have seen almost two questions or 3 questions at a time from the same topic. So that is why it becomes important, because it has aspects from medicine, pathology as well as orthopedics, and therefore it is must that we discuss this topic prior to your examination, and I hope you go thoroughly through this topic so you do not make any mistakes if any question from this topic appears in the examination. Before starting with the topic, I would like to just reiterate and highlight the fact that AFMG is been conducting its test and discussion sessions recently, and I hope all of you just join in and get the benefit from the test and discussion sessions, which will have a lot of test and discussion sessions from team AFMG as well as from the faculties themselves. Apart from that, AFMG has also recently launched the test series only, so where you will get ample amount of MCQs, test series, maybe mini mock as well as mock test according to the schedule that has been given to you prior, and that would be conducted on the AFMG app. So if you wish to join the test series also, please do contact AFMG for that as well. Thank you so much. With this, I begin the session for today, that is for multiple myeloma. Let's discuss this topic in details. If I talk about multiple myeloma, guys, so please remember multiple oma, that means it is some tumor or malignancy, right? So multiple myeloma is also actually a plasma cell dyscrasia. Okay, so please remember multiple myeloma is usually a plasma cell dyscrasia that is seen, or we can call it as a plasma cell malignancy. So what do we mean by actually plasma cells? So please remember, these plasma cells are nothing but differentiated B lymphocytes. Right, so the differentiated B lymphocytes are called as plasma cells, and these plasma cells have a function of antibody production. So these plasma cells are responsible for production of antibodies. Antibodies are also called as gamma globulins or immunoglobulins, right? So please remember, antibodies are nothing but proteins, right? So these antibodies are generally made up of heavy chains like IgG, IgM, IgA, IgD and IgE, as well as there would be production of light chains, that is kappa and lambda. So heavy chains and light chains together makes up an antibody. But in this condition, when there is extensive and abnormal proliferation of plasma cells in multiple myeloma, there would be defective production of plasma cells. These plasma cells which are formed due to abnormal proliferation, these would be defective. So these defective plasma cells which are formed, guys, these defective plasma cells would lead to production of defective antibodies. Why these defective antibodies are formed? Please remember, because only light chains of the antibodies are produced. Please remember, only light chains, that is kappa and lambda chains of the antibodies are produced in excess, and that is why there is production of defective antibodies. And if these defective antibodies or immunoglobulins are formed, then these would not be able to fight the infections in that individual, and therefore the person is at a higher risk of acquiring infections. Okay, the person is at higher risk of getting infections. Most common infection, if they ask you, it is pneumonia. Okay, so the most common infection which the patients of multiple myeloma acquire is pneumonia, whereas they can also acquire pyelonephritis. Please remember this. Okay, now the question can be, which is the most defective antibody which can be seen in cases of multiple myeloma, right? There can be overproduction of any of the antibodies. So the most common defective antibody which is produced is IgG type. So with the help of immunofixation, you can just get to know that which type of antibody is produced in excess. So the most common defective antibody which is encountered in these cases is usually the IgG type of antibody. Right, now if I move further talking about the causes of multiple myeloma, guys, so multiple myeloma, just like another malignancies, can have a lot of causes, and the most important one being radiation. So radiation exposure can be a cause of plasma cell dyscrasia, that is multiple myeloma. Along with that, multiple myeloma can also be seen due to petroleum product exposure. So exposure to petroleum product, which is commonly seen in farm workers or wood workers, in that patients usually there's a high risk that the patients can develop multiple myeloma. So at times the question can start with mentioning a farm worker or a wood worker, right? Important. Along with that, apart from this, definitely there can be some genetic causes of multiple myeloma. So these genetic causes can be mutation in the 13 gene, or there can be deletion of the 17 gene, or there can be some important translocations which are seen. And these translocations are important because questions have been asked on translocations. So please remember, as you remember, chromosome number 8 is related to Burkitt's. That means translocation 28, 814, 822, all of these 8s are related to Burkitt's lymphoma. In the same manner, I would like you to remember that chromosome number 14 in translocations is commonly associated with multiple myeloma. That means the common translocations which are seen in multiple myeloma would be translocation 414 or translocation 1114 or translocation 1416. So this 14 number chromosome is commonly associated with translocations seen in multiple myeloma. Okay, please remember this. If I move further, now if I talk about the clinical features, so the most common symptom with which the patient can present to you is bone pain. Okay, the most common symptom in cases of multiple myeloma is usually bone pain. Okay, so usually in multiple myeloma, the patient is an elderly person who is presenting with a low back ache, right? So please remember, if an elderly patient presents to you with low back ache, the first differential should be multiple myeloma. Whereas if a young adult male presents to you with a low back ache, then the first differential diagnosis should be ankylosing spondylitis. Just get this clear from orthopedics, so it would be much easier for approaching your questions. So the most common symptom in a case of multiple myeloma would be bone pain, right? And why this bone pain is usually seen, it is due to osteolysis. Okay, please remember, it is due to destruction of the bone. That means osteolysis occurs. And why these osteolytic lesions are seen in cases of multiple myeloma? So please remember, these defective plasma cells which are produced, they would lead to release of some cytokines like interleukin 1, interleukin 6, or a macrophage inflammatory protein. So these would lead to activation of the osteoclasts, and once the osteoclasts are activated, they can cause increased destruction of the bone, that is osteolysis, and that can cause osteolytic lesions in multiple bones of the body. So if they ask you which is the first bone to be affected, so please remember the first bone to be affected in multiple myeloma is the vertebra. So the osteolytic lesions in bone are first seen in vertebra, whereas the last bone to be affected is the skull. Okay, please remember, skull is the last bone to be affected. But due to this peculiar X-ray finding that we have in X-ray skull of multiple myeloma, we tend to remember only skull. So please remember, skull involvement is usually seen at the last stages of multiple myeloma. It is not the first bone to be involved, right? So if I talk about the skull involvement, there would be multiple osteolytic lesions in the skull of a patient of multiple myeloma, and these would resemble just like a raindrop configuration. So please remember, this is called as a raindrop skull or a raindrop configuration of skull due to osteolytic lesions in the skull bone, and these are a feature of multiple myeloma. So this is the image which had come earlier also in the examination, so better you remember this properly. Okay, so please remember, usually the vertebra which are involved is the lumbar vertebra commonly, okay, and that is why the patient presents to you with low backache. Along with this, as there is osteolytic lesions in the vertebra, it can also further cause compression of the spinal nerve roots, and the lumbosacral spinal nerve roots are commonly involved. That can cause compression myelopathy in this patient. That can land up the patient in sudden onset paraplegia. Okay, there would be weakness and paresthesias in a patient suddenly. Okay, so that can be due to compression myelopathy which is seen, and if there is involvement of the lumbosacral nerve roots, then that can cause even bladder and bowel incontinence in these patients, right? Then if I move further, talking about the CRAF features. Now CRAF features are important from the diagnosis point of view of multiple myeloma, where let's discuss them one by one. First of all, C goes for hypercalcemia. Okay, C goes for hypercalcemia. That means the serum calcium levels would be elevated. Normal serum calcium levels are usually 9 to 11 mg%, but in this condition, the serum calcium levels would be more than 11 mg%. That is suggestive of hypercalcemia, right? So this hypercalcemia definitely can cause lethargy or fatigability in this patient, and even can land up in some heart problems in this patient, right? Now apart from this hypercalcemia, please remember, it can be due to the osteolysis which is seen. There is destruction of bone which is further contributing to increased levels of calcium in the serum. If I talk about the R that is there in CRAB, so this R goes for renal involvement, or specifically saying it would be renal failure in this patient. So please remember, multiple myeloma patients are very prone for renal failure. We'll discuss the causes of renal failure further. Just remember here, the patients are prone to renal failure. Usually, therefore, the serum creat value in this patient would be more than 2 mg/%. Along with this, there can also be features of uremia in this patient. Right, due to the kidney damage which is seen, there can be uremia in this patient. This uremia can further even progress to uremic encephalopathy. Right. If I talk about A means anemia. So in this patients usually we can find anemia which is seen. Okay, a normocytic normochromic anemia which is seen in this patients, and anemia can manifest as pallor. Right. So please remember, anemia can manifest as pallor, which can be given in the question as well. Whereas B goes for two features. First, B goes for bleeding. Why bleeding is usually seen? So please remember guys, these antibodies which are produced, these defective antibodies which are produced, they will coat the platelets, and these antibody coated platelets, they would not be able to form a effective clot, and that is why there would be bleeding in this patients. Right? So antibody coated platelets are a cause of bleeding in this patient. Whereas B also goes for the bony lytic lesions that are seen. B also goes for the bony lytic lesions that I already discussed why those are seen in this patients. Right? So please remember the CRAB features: C for hypercalcemia, R for renal failure, A for anemia, and B for bleeding and bony lytic lesions. If I move further, talking about the renal failure component in this patient, so there can be various causes of renal failure in this patient, but the leading cause of renal failure in this patient is actually hypercalcemia. Okay, so hypercalcemia can cause calciuria, and that can lead to renal damage in this patient. Apart from this, as we discussed, these people do not have effective antibodies to fight against the infections. Therefore, these people are prone to infections, and one of the infections that I told earlier was pyelonephritis. And this recurrent pyelonephritis in this patient can cause renal parenchymal damage that can also land up in kidney failure. Apart from this, usually these patients have bone pain, and for relief of bone pain, these people are taking NSAIDs, that is non-steroidal anti-inflammatory drugs, on a regular basis, right? And there is excessive intake of NSAIDs by these patients, and these NSAIDs are nephrotoxic, therefore that can also be one of the causes of renal failure. Apart from this, amyloidosis is also seen in this patient. Okay, and as we all know, in amyloidosis, okay, in generalized amyloidosis, the most common organ affected is kidney, as we discussed earlier. So please remember, in amyloidosis also, that can also contribute to the renal failure component. If I talk about the next one, that is hyperviscosity. Now, as we know, the antibodies which are produced, they are nothing but proteins, right? So please remember, these light chains of antibodies which are produced, these are nothing but paraproteins. So excess of paraproteins are being produced in the body, and these excess of paraproteins will contribute to the viscosity of the blood. So the blood will become very viscous, and as there is a highly viscous blood, there would be sluggish circulation of the blood. That can cause ischemia in the patient. Right? There can be ischemia to certain organs in the patient, and the most prone organ for ischemia would be CNS. Right? And as there is sluggish circulation or ischemia to the CNS, the patient can present with features like there can be headache in this patient, there can be visual disturbances which can be seen. Right? Apart from that, there can be some balance disturbances like ataxia which can be seen in this patient. Right? So these are the important things that you need to remember. Now, these are the important symptoms that have already compiled all together. Now, if I talk about the investigations or the workup of this patient, please remember, the first that will run is our complete blood count, that is CBC. In CBC, as we told, that there would be anemia, so the hemoglobin would be less than 10 gram per deciliter, right? Then the platelet count is actually normal. Just the platelets which are reduced, they are coated by the antibodies, and that is why the bleeding component is seen. There can be lymphopenia as well, okay, and that is the cause why there would be recurrent infections. And the most important aspect that you need to see in a CBC is actually the elevated ESR. The erythrocyte sedimentation rate would be elevated, and it would not be normally elevated. It would be elevated as it will show more than 100 mm fall in the first hour. So please remember, it will show more than 100 mm fall in the first hour, and such a highly elevated ESR is only seen in some of the conditions, one of them being multiple myeloma. The other conditions which shows excessively elevated ESR, these are SABE, that is subacute bacterial endocarditis, which is seen due to Streptococcus viridans, and the other important cause is GCA, which is a type of vasculitis, that is giant cell arteritis, also known as temporal arteritis. So in these three conditions mainly, the ESR would be elevated when it shows a fall of more than 100 mm in the first hour itself. Then if I move further, if I talk about the albumin is to globulin ratio, so normally albumin is more as compared to the other proteins, but in this condition there is excess production of the gamma globulins, and therefore the albumin is to globulin ratio would be distorted. Okay, so please remember there is distortion of the albumin is to globulin ratio in this case. If I talk about the kidney function test, that is KFT, here definitely as there is renal failure, there would be a serum creat value more than 2 mg%. Along with that, there can also be features of uremia which can be seen. If I talk about the coagulogram, now the bleeding, as I told you, it is due to the platelet defect. It is not actually due to any coagulation factor deficiency. So the APTT as well as the prothrombin time both would be normal. But as the platelets are defective, therefore the bleeding time would be prolonged. Right? So the bleeding time is prolonged in these patients. Now, if I talk about the axial skeleton of the patient, for evaluating any lytic lesions in the axial skeleton of the patient, we can use imaging modalities like a PET CT or a PET MRI. So if they ask you to choose one, please choose PET CT over PET MRI for any bone findings that we need to see. So please remember, PET CT or PET MRI is generally used to evaluate the axial skeleton where we can find any bony lytic lesions in multiple myeloma. If I talk about amyloidosis now, as I told you, in patients of multiple myeloma, there is secondary amyloidosis which is seen due to deposition of the AL type of amyloid. Okay, so that as that light chains are actually depositing in multiple organs, that can cause amyloidosis. So this secondary amyloidosis, for that the investigation of choice, as we have discussed earlier also in one of the test and discussions, it is abdominal fat pad aspiration. So please remember, the investigation of choice for amyloidosis is usually abdominal fat pad aspiration. Okay, and we can use stainings like a Congo red stain can be used for this. Okay, for diagnosis of amyloidosis. If I talk about the genetic studies that we run, that is FISH usually. Okay, that is fluorescent in situ hybridization. So FISH will show us any translocations. So please remember, translocation as we discussed, that is translocation 11-14, translocation 14-16, translocation your 4-14. These would be seen in FISH. Okay, please remember this. If I talk further about the screening test of this condition, so it is usually either a serum or a urine electrophoresis. Okay, it is a serum or a urine electrophoresis which is the screening test of choice in these patients. So if we run an electrophoresis, this is a picture that we get, okay, in multiple myeloma patients. Normally, as we know, albumin is the most abundant plasma protein, so it will have the highest peak. Then comes the alpha 1, alpha 2, beta globulins and the gamma globulins. So gamma globulins are usually less as compared to albumin in normal patients. But in patients of multiple myeloma, there is excessive increase in the gamma globulins, that is our defective antibodies which are there. So right, there would be a peak which is seen in gamma globulins too, almost equivalent or more than that of the albumin. So this is known as the M peak. So please remember, this is known as the M peak, also called as the M spike, okay, or also known as the M component. So this also is known as the church spire, okay, appearance which is seen. So a church spire appearance on serum or urine electrophoresis is usually suggestive of multiple myeloma. Right, so for further confirmation of our diagnosis, the investigation of choice for multiple myeloma, please remember, it is a bone marrow biopsy. Okay, the investigation of choice is a bone marrow biopsy or a bone marrow aspiration, whatever we can do, right? And the bone marrow biopsy or bone marrow aspiration should show us more than 10% of plasma cells. It should show us more than 10% of plasma cells. That is considered as bone marrow plasma cytosis, which is seen, right, on a biopsy. That is diagnostic of multiple myeloma. if they ask you which is the best test for prognosis of multiple myeloma, that means the patient would have a good prognosis or a bad prognosis. So for that we have a test called as urine beta 2 microglobulin levels. Okay, urine beta 2 microglobulin levels. So we will assess the levels of urinary beta 2 microglobulin, and depending on that we can conclude that whether the patient will have a good prognosis or a bad prognosis. So if they ask you the best test for prognosis, it is urine beta 2 microglobulin levels in the patient. These urine beta 2 microglobulin along with serum albumin is also used for staging of multiple myeloma, but I think at least if you do not remember the staging, it's fine, but at least all these other facts are important for you to be remembered, because staging usually is asked in INA set or NEET PG examinations. If I talk about the pathology aspect of multiple myeloma now, okay, if I talk about pathology, the first thing that comes to my mind would usually be flow cytometry. So these plasma cells, also called as the myeloma cells, these on flow cytometry would show us CD138 positivity. So please remember, if a flow cytometry shows CD138 positivity, that is suggestive of myeloma cells or plasma cells, right? Please remember this. Now if I talk about the histopathological examination of the bone marrow biopsy that we have got, so in HPV usually we can find three important findings. The first one that you can see in this image has come earlier in the examinations multiple number of times. So here you can see that the light chains of the antibodies, they try to accumulate in the cell, okay, and this accumulation of light chain in the cell, that would lead to a appearance of grape-like inclusions. There would be a grape-like inclusions which is seen in the cell, and these cells are called as the Mott cells. So please remember, these cells are called as the Mott cells. These are important to be remembered. Then if I talk about the next picture, usually the next picture is of the right hand Giemsa stain, definitely a H&E stain, the pinkish one can also be given to you. Okay, in this usually we need to remember two important inclusion bodies. Okay, both of them are intracytoplasmic inclusion bodies. Yes, most of the books say some like Dutcher body is an intranuclear one, but I'll tell you why not it is an intranuclear inclusion body. So please remember, here you need to remember two important inclusion bodies, again due to the accumulation of light chains inside the cell. Okay, the cause is same. So here you can see a intracytoplasmic inclusion body that is usually seen. This is known as a Russell body. The intracytoplasmic inclusion body which is seen is known as the Russell body, whereas the other one that can be seen in the nucleus. So please remember, the other one which can be seen in the nucleus is known as the Dutcher bodies. Okay, the other ones are known as the Dutcher bodies. So both of them are intracytoplasmic, but Dutcher bodies usually have an overlap on the nucleus, and that is why they are considered to be intranuclear pseudo inclusion bodies. Okay, at times. So please remember, at least you can remember that intranuclear pseudo inclusions are Dutcher bodies, whereas intracytoplasmic inclusion bodies are Russell bodies. So these two are the bodies which are usually seen in cases of multiple myeloma. Whereas the last picture that you can see from histopathology, here you can see that the nucleus of this plasma cell is having a peripherally arranged chromatin, and this peripherally arranged chromatin just gives an appearance of a clock face. So this is called as a clock face chromatin. So clock face chromatin of a plasma cell is usually seen in cases of multiple myeloma. Along with that, there can be a perinuclear halo or a perinuclear clearing which can be seen in this condition. I hope with this the pathology aspect is also clear. Next, if I talk about the criteria for diagnosis of multiple myeloma, guys, usually it is diagnosed as any one of the CRAF features should be present. Any one of the CRAF features should be present, along with the electrophoresis showing a M component or a M spike, electrophoresis showing a M component. Along with that, the bone marrow biopsy or the bone marrow aspiration showing plasma cell count of more than 10%. Okay, showing a plasma cytosis of more than 10%. So these three are mandatory for diagnosis of multiple myeloma. Any one of the CRAF features, along with that M component on serum or urine electrophoresis, along with that bone marrow biopsy showing plasma cytosis of more than 10%, a diagnostic of myeloma. If I talk about the other condition now, nowadays according to the recent guidelines that we have, even in absence of CRAF features, we can diagnose multiple myeloma. How that can be done? So please remember, even in absence of CRAF features, multiple myeloma can be diagnosed, but that has certain conditions. So the first condition that we have usually in this the bone marrow plasma cytosis should be more than equal to 60%. Okay, the bone marrow plasma cytosis should be more than equal to 60%. Or apart from that, there should be a abnormal serum free light chain ratio. Okay, abnormal serum free light chain ratio of more than equal to 100. Okay, so this can be seen in this patient. Along with that, there can be a MRI finding which shows one or more lytic lesions more than 5 mm usually. Okay, so one or more lytic focal lesions which can be seen on an MRI which are more than 5 mm. So at least if you cannot remember that, the first criteria should be remembered. Okay, at any cost, any one of the CRAF features plus electrophoresis showing M component plus bone marrow plasma cytosis of more than 10%, right? Even if there is absence of CRAB, multiple myeloma can be diagnosed with the help of one of these features, right? If I talk about the treatment of multiple myeloma, it can be remembered as BLS. BLS is the mnemonic. So where B goes for bortezomib. Bortezomib is a protease inhibitor which is used. Okay, so please remember B goes for bortezomib. L goes for lenalidomide. So lenalidomide is a anti-cancer drug usually used in chemotherapy. So lenalidomide is also used. Along with that, S goes for steroids. And the most preferred steroid that we use generally in cases of multiple myeloma is dexamethasone. So the treatment regime that we use in cases of multiple myeloma is BLS, bortezomib plus lenalidomide plus steroids like dexa. If they ask you the treatment of choice or the best treatment for a multiple myeloma patient, it is generally a autologous stem cell transplantation. Okay, the best treatment would be a autologous stem cell transplantation. So please remember, autologous means from the same body. So from the patient's body itself, there would be a stem cell transplantation that would be done. If I talk about allogenic stem cell transplantation, that is generally performed in many of the conditions. Allogenic means from the same species. That can be a mother, father, sister, brother, anybody. Okay, but autologous means from the same body, right? So please remember, these are the things that you need to remember about multiple myeloma. But at times that can happen. They have given you a case, but there is no mention of any myeloma defining events. So please remember, myeloma defining events, by that I not only mean the CRAF features, but recurrent infections or any of the bony lytic lesions. Okay, all of these, or hyperviscosity features, all of these can be considered as myeloma defining events which are suggestive of end organ damage in cases of multiple myeloma. So none of these features are present. Okay, in case 1, no myeloma defining events are present. Only they have given that the bone marrow plasma cell count is less than 10%, whereas plasma cell M component is less than 30 gram per liter. So definitely it is not multiple myeloma at any cost. Bone marrow plasma cell should be more than 10%. Here it is not. Then M component should be more than 30. It is not. And apart from that, no myeloma defining events. So definitely it cannot be multiple myeloma. In this condition, it is diagnosed as MGUS, that is monoclonal gammopathy of unknown significance. Okay, monoclonal gammopathy of unknown significance. Whereas if I talk about the case 2, here also there is absence of any myeloma defining events. Only they have given bone marrow plasma cell count more than 10% along with plasma M component of more than 30 gram per liter. So these two features are in favor of multiple myeloma. Like bone marrow plasma cytosis is also there more than 10%, whereas plasma M component is also seen. But there is absence of any myeloma defining events. Okay, and as myeloma defining events are absent, again it cannot be counted to as multiple myeloma. Therefore it is diagnosed as smoldering myeloma. So please remember, this condition is diagnosed as smoldering myeloma. Whereas the third case can be, there is no mention of any myeloma defining events, no bone marrow plasma cytosis, no M component in plasma. Only they have given that the plasma cell count in the serum is more than 2000 cells. Then this condition is counted to as plasma cell leukemia. Then this condition would be diagnosed as plasma cell leukemia. Right? If you cannot remember these three cases, at least I would request you to remember all the features that we have discussed about multiple myeloma, because this is a very important topic, guys, and that's why I request you to remember the important findings that we have discussed about multiple myeloma today. Thank you so much. Let's meet in another session. Till then, goodbye, good luck, and take care.